Vishal sir, we can start this.
Yeah, sure. We can start.
Good morning, sir. Our patient, 57-year-old lady from Bharatpura, Rajasthan, occupationally a homemaker, came with chief complaints of upper abdominal pain since 10 days and yellowish discoloration of eyes and high-colored urine since 10 days. History of presenting illness. Patient had pain in right hypochondrium since 10 days, which is insidious in onset, intermittent type, dull aching, and moderate in intensity. Pain relieved after IV medications. And there was no history of radiation to back, and it was not related to food intake or postural change. Coming to history of presenting illness, patient gives history of yellowish discoloration of eyes and high-colored urine since 10 days, which was noticed by her treating doctor, which was insidious in onset, progressive in nature. There was no history of passing clay-colored stools, and it was not preceded by any prodromal symptoms. It was associated with generalized pruritus since 10 days. It was present throughout the day, disturbing sleep and lifestyle, and it was relieved after medications. There was no history of loss of appetite and no history of loss of weight. There was no history of similar upper abdominal pain in past, and there was no history of fever, no vomiting, no melena or hematemesis, no bleeding per rectum, no abdominal distension, no shortness of breath or cough, no headache, seizures, blackouts, and no back pain or body pain. Past history, she is a known case of hypertension since 7 years, is on regular medication. She is known hypothyroid since 2 years and is on medication. She has no history of diabetes, tuberculosis, and asthma, and patient was hysterectomized 10 years back due to dysfunctional uterine bleeding. Personal history, patient consumed mixed diet and she has disturbed sleep since 10 days, regular bladder and bowel habits, and she has no addictions. She's para 3, life 3, and hysterectomized 10 years back. Family history was not significant. To summarize, she is a 57-year-old lady with no addictions, known hypertensive and hypothyroid, on medications, presented with painful progressive jaundice associated with pruritus since 10 days. There was no history of loss of weight and no history of loss of appetite. I would like to consider it to be obstructive jaundice, most probably due to stone disease, sir. Sir?
Please continue.
Yes, sir. I would like to consider DDs. First being choledocholithiasis. Second, mirices. I would also like to consider carcinoma of gallbladder, hilar cholangiocarcinoma, and carcinoma of head of pancreas also. Here, I would like to consider carcinoma of gallbladder because the patient is from North Indian belt.
No, that's not it.
Yes, sir.
So we will discuss about all these differential diagnoses in sequence. Right?
Yes, sir.
So
Yes,
first you have mentioned about the CVD score, then mirizi, and then you are considering the malignant process, right?
Yes, sir.
So before we go to the differential diagnosis, few things in the history that I would like you to clarify. Why you ask history of seizures and blackouts? So what is the significance or relevance in this context of current presentation?
Yes, sir.
So she is a short history, 10 days history. Everything is started in the last 10 days of the pain, jaundice,
Yes, sir.
and pruritus.
My motive in asking seizures was, sir, it is a carcinoma of gallbladder which would present at a very late stage, and it would also some with metastasis. So firstly, I asked for headache and followed by seizures and blackouts to complete the history, which would be caused by any space occupying lesions metastasizing to the brain, sir.
Suppose there is a positive history of seizures.
Sir.
Right. Or positive history of headache, blackout.
Yes, sir. Headache, I would like to consider it to be.
You will suspect SON in the brain because of malignancy, and most probably you are thinking of carcinoma. Right?
Yes,
I would say she is a hypertensive patient.
yes, sir.
Why don't you think it's uncontrolled hypertension which is causing such kind of symptoms? Headache, blackout,
Yes, sir.
rather than a very rare situation of a malignancy from the abdomen,
Yes, sir.
which
I
is
I asked.
metastasizing into the brain and presenting as a seizures as a first presentation. How commonly have you seen? Because North India is a common belt for
Yes, sir.
carcinoma gallbladder. So how commonly is this seizures as a first presentation of carcinoma gallbladder when there is no history of, I would say, anorexia or weight loss?
Not at the first presentation, sir. I took it for the sake of completion, sir.
For the sake of completion. And what about this postural change? You mentioned that pain uh, did not change with relation to the posture. So what is the again clinical relevance? You
Sir,
mentioned, I think, that
yes, sir. While usually bending forward causes relief of pain in pancreatic pain, sir. Pain
which
abdomen.
kind of pancreatic pain?
Yes, sir. I want to rule out
Which kind of pancreatic pain? All. So any pathology involving
chronic
pancreas.
pancreatic pain, chronic pancreatitis pain, sir.
So are you suspecting chronic pancreatitis in this patient, or just again it is for the sake of
Yes,
completion?
sir. For the sake of completion, I have asked it, sir, because I have to rule out the pain, the origin of the pain, whether it is from the gallbladder or the pancreas. So I have also asked it in detail whether postural change and also.
So if there is a change in the patient has a relief in pain because of forward bending or posture change.
Yes, sir.
So it will differentiate between pancreatic pain and the pulmonary pain. You think so?
It won't really differentiate, sir, but I would like to then consider pancreas also would be a cause. I would also like to consider pancreatitis and
So
or
again, we will discuss about the differential diagnosis,
yes, sir.
right? So if we look at the history part, right? What do you think? What is the pathology which is going on? It is a benign pathology. It is a malignant one.
Sir, according to the history, most probably it would be a biliary pathology due to a stone disease, sir, because it is the first presentation only since
No,
10
no, no. See,
and there
I
is
have just specifically asked it is a benign pathology or it may be a malignant. So you just
benign,
mention whether it is a benign or malignant. Then we will discuss about what could be the benign, right? Or what could be the
yes,
malignant.
most probably benign, sir, because there is no loss of weight and no loss of appetite, sir.
Right? And what would be the more important complaint or symptom which will suggest you that it is not malignant, it is benign disease? Is it a painless progressive jaundice or it is a painful progressive jaundice?
Sir, if it
Or
is a
organization?
painless jaundice, then it
Not
would
if,
more likely be in a
this,
malignant
see,
site.
see, we are talking about this patient, right? So, what is the presentation of this patient?
This is a painful progressive disease, sir.
Right. So, this is a painful progressive disease. This is a short duration. There is no history of anorexia. There is no history of weight loss, right? So,
Yes,
most likely, this patient is having some benign pathology, which is causing all her symptoms. And what could be the benign pathology?
most probably stone disease, sir.
Stone disease.
Sir.
Why stone disease?
Because it is the most common cause of obstructive jaundice, sir.
Stone in the common part,
Stone in the skin.
right? Stone in the common part, right?
Yes, sir.
Okay. So this was your first differential diagnosis.
Yes, sir.
And what about Grisey syndrome? You mentioned about Grisey syndrome.
Yes, sir. I would also like to consider a duct disease, cystic duct disease compressing the common bile duct, sir. So I kept it as my second DD, sir.
What about colorectal cyst?
Sir, as my patient is a 60-year-old, I would like to consider it, but not at this age, sir. She would have presented earlier at a very young age, sir. But I would also like to consider it.
Why not chronic pancreatitis with CVD structure?
Sir, she has only 10 days history. It may be the first episode of chronic acute pancreatitis, but as the pain was not typically in the epigastrium and no postural change, no radius change to back, and it was towards the right hypochondrium. I thought it would the origin of the pain would be gallbladder and CBD, sir. Incoming video call.
Why not hereditary cyst of the liver complicated by cystobiliary communication or obstructive jaundice?
Yes, sir. Hereditary cyst, very large cyst compressing the CBD causing jaundice is a very rare presentation, sir. Usually they present with dull aching, right hypochondriac pain, mostly without jaundice, sir.
What about, okay, so we have discussed about this thing. Why not liver abscess?
Sir, usually, yes, sir. Patient would have presented with fever, sir, if it was such a huge liver abscess causing obstruction and causing jaundice. But as she has no fever, I would not like to consider it, sir.
So why in malignancy we have mentioned about carcinoma?
Yes, sir. Because this is North Indian belt and there is high incidence of occurrence of carcinoma of gallbladder, typically in this age of patients, I would like to consider it as a DD, sir.
How severe is the pain?
Sir, usually they present with painless progressive jaundice, sir, carcinoma of gallbladder.
In this patient, what is the intensity of pain in this patient?
Pain she had moderate to severe intensity, sir.
She required injectable analgesics?
Yes, sir. She required injectables for 1 day, sir.
Just for 1 day? Yes, sir. So in which situation of carcinoma of gallbladder, patient will require such kind of analgesics?
Yes. It may be a acute cholecystitis presentation of a carcinoma of gallbladder, sir, which required IV medications.
Okay. What are the usual scenario in which the patient with carcinoma of gallbladder require strong analgesics or injectable analgesics?
Yes, sir. Most probably advanced carcinoma of gallbladder infiltrating iotocaval bone and posterior retroperitoneal space.
Carcinoma of gallbladder which is directly infiltrated or it is something else?
It is metastatic mostly, causing bony pain and.
Is a bony pain or something else? What is the cause of pain in carcinoma of gallbladder? If it is a severe pain, is it a bony pain or is it something else?
Due to local infiltration of the gallbladder, there will be pain, sir. Into the nerves, posterior nerves. Neuronal infiltration would cause pain. Yes, sir. Neuronal infiltration. Yes, sir.
It is an extensive disease. Not only it is a locally advanced disease because of correct infiltration, it is an extensive retroperitoneal. Right. It could be a retroperitoneal infiltration in the area or around the celiac axis. It is infiltrating the local nerves, causing neuropathic pain. So if patient is having severe pain requiring injectable analgesic in the scenario of having carcinoma of gallbladder, right? What other symptoms patient will have besides pain? Because it is an advanced disease.
If it is an advanced disease, the patient would present with local infiltration.
Other symptoms. Yeah, it is a local infiltration. So one of the manifestation of local infiltration is?
Yes, sir. One, it may infiltrate the extrahepatic biliary apparatus and present as jaundice like in our patients, sir. Two, it may infiltrate into the duodenum and cause obstruction or partial obstruction, sir. Three, it may infiltrate into the stomach and cause gastric outlet obstruction kind of picture.
Same, it is a stomach or duodenum, right? And
And 4, it may present as peritoneal mets, and it may present as ascites.
So it is a distant disease. Right?
Yes, sir, dystonia.
So there will be some other symptoms. So most important being the patient will have anorexia, the patient will have some weight loss, besides having a jaundice.
Yes, sir.
So these symptoms like just pain abdomen and just jaundice, right? And a locally advanced disease or metastatic disease or overall advanced disease cannot be there in the ICU. There must be some other symptoms, especially there are symptoms of for short duration, just 10 days. And then why hypercholinic carcinoma?
Sir, here my patient also has pruritus, sir, which was almost at the time of jaundice presentation. So I would also like to consider it to be a...
Pruritus is a specific marker of hypercholinic.
No, sir, not really. But usually, hilar cholangiocarcinoma, we see patient presenting first with pruritus followed by jaundice. But this patient has almost near a presentation, so I thought of considering it, sir, as a second reading.
And then any other?
Yes, sir. I would like to
about
carcinoma. Yes, sir.
So it may be any periampullary carcinoma, but do you think that periampullary malignancy or CA hepatitis, or in fact any malignancy presenting with jaundice, they usually have moderate to severe pain in general?
Yes, sir.
It's less likely. So overall, most likely this patient is having some benign disease. Yes. Most likely some stone disease. Okay.
Yes.
So you put as a first differential diagnosis. Yes. So go ahead with the examination.
Yes, sir. Coming to general physical examination, she is a young female, averagely built, nourished, with height of 160 centimeter.
Dr. Manoj, do you want to ask any question from?
No, sir.
Okay.
Weight of 72.4 kgs, and she has a BMI of 28.2, which she was overweight, and her performance status ECOG was 1. She's conscious, coherent, cooperative, well oriented to time, place, and person, and lying comfortably on bed. Her pulse rate was 84, BP was 140 by 80, was on medication, and respiratory rate saturation were normal. Coming to general physical examination, icterus was pleasant, no pallor, no pedal edema, and there is no supraclavicular lymphadenopathy. There were no scratch marks also, as the patient was relieved of pruritus now. And coming to examination of abdomen, abdomen is flat, umbilicus is central in position and inverted, all quadrants move equally during respiration, no mass, sinus engorged veins, pulsation, and peristalsis. On inspection, it was normal. On palpation also, abdomen was soft, no local rise of temperature, and there was no tenderness. Gallbladder was not palpable. Actually, she was obese, sir. So there was a thick abdominal wall.
She's obese. Sure.
Overweight. She was 28, sir, BMI. So the abdominal wall was thick, and I couldn't palpate any gallbladder, sir.
Okay.
No other masses or organs palpable. Hernial orifices are normal. External genitalia are normal. On percussion, liver dullness started at 15 intercostal space, and there was 12 centimeter of liver span in mid-clavicular line. Abdomen was resonant on percussion. Auscultation, normal bowel sounds were heard. Perrectal examination, perianal skin was normal. Sphincter tone was normal. Mucosa was normal. No mass was palpable. And normal fecal staining of the finger was present, and there was no blood. PV was normal. Respiratory system and CNS examination were normal. To summarize, additionally...
Just a minute. Why did you perform PV? What is the levels?
Sir, I performed it for the sake of completion, sir, only to see for Bloomer shelf and a mass in the Bloomer shelf.
Do you think PV is required to assess this Bloomer shelf?
PR would be enough, sir, but I did it for the sake of completion.
So all female patients presenting with abdominal symptom, irrespective of the context or any indication specific for PV, you should go ahead with the PV.
Yes, sir. Shall I continue, sir?
Please.
To summarize, additionally, I was able to appreciate only yellowish discoloration of eyes in the physical examination, and my DD would be the same, sir.
Go ahead. So, did you mention about the medical history in the past 10 days? Because you mentioned that she had some response to some medicine for pruritus she has taken. So, what is the medical history in the last 10 days? Was she visited somewhere else? What was the
Uh,
medicine she was prescribed?
10 days back, she was admitted to a local hospital where she was managed with IV painkillers, sir, after which she was relieved of pain. And then she underwent an ultrasound and was referred to us, sir.
Right. So, you mentioned the
So I would
same.
like,
So, you are not changing your differential diagnosis, sequence of differential diagnosis, right?
no, sir, no change, sir.
So, what next?
Yes, sir. I would like to investigate her, sir. First, I would like to
You
run
don't
a.
want to. You don't want to review her records.
Yes, sir. I want to review. I have reviewed her report.
What would be the more logical sequence of
Yes, sir. First,
investigation?
review of reports.
Yes. So we
Then,
start with this thing because patient already underwent some kind of investigation elsewhere.
yes, sir.
Right. So you are sitting in the OPD, patient has come to you. You have assessed her symptoms. You have examined her. So the next sequence would be to review all the records so
Yes,
that you are guided better. Uh, like how you approach further, which investigation you would like to get on. For example, the patient already had LFT 2 days back. So is there any point of repeating that LFT? Or suppose patient already had a ultrasound 2 days back, which is quite reliable. There's
yes,
no point repeating it, right?
yes, sir.
So I think it's, at this stage you better say that you would like
Review.
to review the reports, okay? And then you start with reviewing those reports.
Yes, sir. Actually,
Sir, I
she.
would like to add something just for a comment regarding the differential diagnosis of this patient. As Sindhu told, that after the benign causes, the malignancy first CAGB and second is a hilar cholangiocarcinoma. As a patient having typical symptoms of abdominal pain with jaundice and pruritus, I think we shouldn't keep the hilar cholangiocarcinoma in the differential diagnosis. As the patient having typical pain, so the patient of the jaundice with pruritus with pain, we have a typical in malignant causes like CAGB with hilar block or CAGB with lymph node involvement of the hilum. Number one. Number two, head of pancreas mass, and very lower down the hilar cholangiocarcinoma. But in this patient, what the only 10 days history is here, so we can't differentiate benign and the malignant cause, as the benign causes maybe have a longer duration of the history, but we can think of benign first and then malignancy, and we should keep the hilar cholangio lower down. This is my comment, sir.
Yeah, I think she has already put the carcinoma the last one, but I do agree that carcinoma should not be there in the list of babies.
Yes, sir. We can go forward.
Yes, sir. Actually, she came with an ultrasound report, sir, which was which was doubtful of, which was showing a neoplastic etiology from the gallbladder, sir. So we have repeated ultrasound at our place, and it showed intrahepatic biliary channel dilatation with gallbladder having an irregular thickened soft tissue density area, sir, showing vascularity on color Doppler, and was query neoplastic etiology with proximal CBD, which was 11 mm with hyperechoic area in CBD, sir. Most probably mass in the CBD also. So we suspected carcinoma of gallbladder, sir, in this patient with infiltration into the CBD, and we have done a contrast enhanced CT, sir. And we also got investigations done, blood investigations.
Just hold it. You read this ultrasound report again.
Yes, sir. Ultrasound of whole abdomen. Liver was normal in size.
No, liver is normal. Just focus
Yes.
on the abnormal findings.
And intrahepatic biliary radical dilatation was present. They did not mention central peripheral. And hepatic veins and portal venous radicals are normal, which means portal vein was intact. And here they did not mention about any.
Yes, I'm just asking you. Just read the
The gallbladder wall appeared irregular, thickened. They did not mention the size.
Okay.
And soft tissue density area noted in the gallbladder wall, showing vascularity on the color Doppler. They did not mention the site also, sir, whether the fundus, the body, or the cystic duct. And fat planes with the liver, they have mentioned that it is maintained. And they have mentioned that the proximal common bile duct is infiltrated, most probably, with hyperechoic area in the CBD.
Why do you think it is infiltrated? This is your interpretation.
Yes, sir. Yes, sir.
Your interpretation is that this is infiltrated or this is something else?
Yes, sir. This may be a lymph node causing obstruction also to the bile duct.
See, you read it. Proximal common bile duct 11 mm with hyperechoic area is reported in the CBD lumen. It is a CBD lumen. Very mass, very sludge. So do you think this line suggests that it is infiltration or it is something else in the lumen of common bile duct?
It may be primary of the common bile duct also, sir.
Why do you think it is a primary? It is a hyperechoic area within the lumen of the CBD. See, what are the important findings which are missing in this ultrasound? Which do you think that those findings are important in terms of deciding further imaging, whether it is a CT scan or MRI? What about gallstones? Have they mentioned about gallstones?
No, sir, they did not mention anything about gallstones.
For differential, first was cholelithiasis.
Yes, sir.
Obviously, patient has there is no history of mastectomy. You expect gallstones also in the gallbladder, right?
Yes.
So there is no mention of gallstone in this ultrasound. First, they are mentioning all the findings which is suggestive of some neoplastic lesion of the gallbladder. Second, there is a hyperechoic lesion within the lumen of the gallbladder. So they are suspecting whether it is a mass. If it is a mass, it may be it is a synchronous lesion is very unlikely. It is a rare situation. Most likely it is something coming from the gallbladder itself. It may be a tumor embolus. Second, it may be a CBD stone or sludge bond.
Yes, sir.
Right. So
Yes.
that become important. Not necessarily it is a direct infiltration. What my point? Then they have not mentioned what is the extent of this biliary obstruction. What is the level of biliary obstruction? They have not mentioned about the conference, CSD, distal CBD. Like we have already mentioned, they have not mentioned the central or peripheral IgA, which part of the biliary system is damaged. So we are not able to ascertain what is the level of biliary obstruction, except that they have mentioned that something is there in the lumen of the CBD. And then CBD is 11. Right. And then there are few para-aortic lymph nodes. So they have not given any impression. They have just advised for advice.
Yes, sir.
So based on this ultrasound, what is your impression first? Then we will talk about the next investigation.
Yes, sir. It would mostly be I would like to consider two DDs, sir. One, stone disease, as we already thought, and two,
Stone disease
mass disease.
Stone disease where?
In the CBD, sir, proximal CBD. Where they
first you talk about the gallbladder.
Yes, sir.
Very
First,
clearly you can see some region in the gallbladder. So yes, most likely it may be a
gallbladder mass carcinoma.
It is a neoplastic region of the gallbladder. Second is region is there in the CBD. So it may be a neoplastic, it may be stone disease.
Yes, sir.
What method? No.
Sir, can you please repeat?
What is your interpretation based on this ultrasound?
Sir, I would like to consider carcinoma of gallbladder as first DD,
One
sir.
pathology, one pathology, second pathology.
With lymph nodal infiltration into the proximal.
No. In the bile duct. See, they have mentioned two pathology. One in the gallbladder, which is abnormal, which is thickened, and there is a soft tissue density in the GB wall. Most likely, it is a carcinoma gallbladder or neoplasm of the gallbladder. We don't know the exact history.
It has stone disease in the
Second, there is a pathology in the proximal common bile duct, which is already dilated. This pathology is whether a neoplastic lesion or it is a sludge below.
Yes, sir.
So basically, there are two pathology. It is the second pathology in the common bile duct which is causing jaundice.
Yes, sir.
Okay. So now we have to clarify what is the nature of these lesions in the gallbladder and the common bile duct.
Yes, sir.
So what is the next investigation you would like to do?
So we also got blood investigations done, sir. I'll quickly finish this. Her bilirubin was raised. It was 9.4 with raised direct bilirubin. Her CBC was normal and mildly raised ALT and AST. Albumin was normal, sir. CA99 was also raised. It was 69.9, sir. And next we got CECT done, sir.
Just hold it. Did you get the CRP, C-reactive protein? No. Okay. So why do you think this AST ALT are raised? Are they normal? AST is 300 and ALT is more than 170, right? So what is the normal upper limit?
Sir,
In
30,
general,
50, sir. 30 to 50.
30 to 50.
Mm.
Right? So even if it is 50,
Double, more than double.
3 times, more than 6 times. What do you think could be the cause?
It may be due to the common bile duct obstruction, which is causing liver cell inflammation, sir.
Cholangitis.
Actually, as such, cholangitis picture is not yet set in, sir, because alkaline phosphatase is normal and counts are also normal. I would not like to commit to
Alkaline phosphatase is common. What is the normal range?
150 was the normal range.
Okay.
150, sir. So not yet set in, but it may, sir, in this patient.
So this LFT picture is matching with your ultrasound and clinical ultrasound and clinical scenario.
Yes, sir. It is going in hand, sir. That total bilirubin is raised, supporting EDD obstruction.
But why alphos is not raised if it is obstructing the raise?
Yes, sir. It may be a partial obstruction, sir. So
see, alphos is a very, I would say, specific and sensitive for obstruction.
yes, sir.
So even if it is a partial obstruction, it will be raised. We don't have gamma GT here.
Yes, sir. GGT.
So when what is done, it is a very recent one or this is a single report?
Yes, sir.
Okay.
Recent one.
Anyway, go ahead. So this LFT is not matching actually with the ultrasound report. So you've got the CT scan. So what are the CT scan findings?
Yes, sir. Sir, CT scan findings, sir. Here in the coronal view, can you see, sir? There is a mass in the gallbladder, sir, at the fundus, and it was.
Use your cursor to point out where is the lesion.
Yes, sir.
Will you be able to do it?
Yes, sir.
So do you have background images or just static images?
No, sir, I have video also, sir.
Mhm.
I would like to once show you this, sir. There was a mass here, sir. And here there was direct infiltration into the CBD, sir. This is the CBD, sir. And here there was infiltration, sir.
I'm not able to see your cursor. Where
The
you are.
infiltration, sir, of the ball. I would like to show the video, sir.
If you want to play the video of the CT scan, then you need separate software in iPad. You have sent me the video. I'll try to play this video.
Yes, sir.
हाँ था डी में था वो क्या पेपर हाँ डाउनलोड क्या था डी में हाँ डी में हाँ CHB का पीपीटी
Sir, I have sent you the PPT. Which is included of the videos, sir. Can you please?
Yeah, yes, I'll please stop share and I'll share the PPT.
Yes, sir.
Yeah. There is the PPT. This is the PPT. You can see my screen?
Yes, sir, I can see.
Can you see the video running in the?
No, sir.
No?
Not yet.
Can you see the
I can see the presentation, sir. It is in the first slide.
duplicate? Now can you see the video?
Yes, sir.
Is it playing?
It is not playing yet, sir.
क्या है वीडियो हाँ वीडियो ऐसा मतलब नहीं
Okay, anyway, you can describe the report, CT scan report.
Yes, sir.
Playable है
Sir, CCT.
Now can you see the video? Sindhu?
Yeah, I think you can scroll it. I think.
Yes, they have made very fast. Now, Sindhu, can you see the video?
I can see it.
Yeah. Probably she lost the connection. Sindhu, hello, Sindhu. Sindhu, you are in now? Probably she lost connection.
I would like to discuss the CECT report, sir, meanwhile.
No, it is. I think you can see the
Yes,
films.
sir.
You
Yes,
can see
go
the
ahead.
video now.
Yes, sir. Coming to plain video, sir, I'm able to see the lower lobes of the lung, which have no consolidation, no pleural effusion. The liver, I am able to see intrahepatic biliary dilatation and some thickening in the gallbladder fundus, sir. And the CBD is dilated, and there is no ascites as such. And I'm able to see some contrast in the bubble loop, sir, here and there. Coming to the arterial phase, sir.
Now, this is the venous phase. Okay.
Okay, sir. Arterial phase, sir.
Okay.
Same, sir. I can see biliary radical dilatation, and there is a irregular thickening of the gallbladder wall and heterogeneous mass in the gallbladder fundus. Coming to the portal phase, sir. There is IHBR. The portal vein has been formed, and the mass is quite away from the portal radicals. Portal vein is almost safe, sir. And I have also checked for arterial anatomy, so there were no aberrations, and common hepatic artery is away. And in the portal phase only, I have shown a coronal image, sir, in which there was direct infiltration of the gallbladder wall into the proximal biliary duct, sir, which I have drawn and shown. Next one, sir. Next slide. Yes, sir, here. And the report was liver was normal in size, outline attenuation. They did not mention about IHBR here. And the gallbladder, a concentric irregular mural wall thickening is seen involving fundus and adjacent body region of gallbladder, forming a mass measuring 3 × 2 cm surrounding liver parenchyma with maintained plane. So liver has maintained plane, no liver infiltration, likely neoplastic. There is a short segment concentric enhancing thickening of proximal CBD, around 1 cm. Hepatic ducts measure right at 7 mm, left 7.5 mm with dilated IHBR. Query malignant thickening or query inflammatory. And they also have mentioned there are a few enlarged necrotic pre- and para-aortic iotocaval and portal region lymph nodes, largest of 16 to 10 mm at portal, possibly metastasis. Pancreas is normal, kidneys, spleen normal, sir. Everything is normal, and minimal free fluid in the pelvis, sir. So actually, they did not mention about any lymph nodes which were near the CBD, sir. And they have surely mentioned about the para-aortic lymph nodes. So most probably this is a
They have mentioned portal region lymph nodes.
Portal they have mentioned, sir, near the CBD and all they did not mention. Yes.
What is portal region lymph nodes?
Around the CBD, retroportal and all, they did not mention it, if they have seen any or not. And they did not clearly mention about the portal vein, is it safe or not? and they did not mention about the arterial anatomy. They did not mention about common hepatic artery. Is it safe or not? And these things, sir. And they did not
See,
mention about the duodenum, whether it
no,
is
no, no.
free from the disease or
What
not.
is your interpretation based on the CT scan finding and
Yes.
based on the CT scan you have seen?
Yes, sir.
Where is the primary lesion?
Yes, sir.
And
Primary
what are
lesion
the
is the
other lesions?
gallbladder infiltrating into the
Where is the gallbladder? Which
fundus
portion
of the
gallbladder?
fundus of the gallbladder, sir. There is a polypoidal mass into the lumen and also wall thickening of the gallbladder,
It is a
sir.
polypoidal mass, sure.
Yes, sir, it was occupying the fundal region. So it was a
See,
mass.
they are two different. See, they are two different things. Is it a polypoidal lesion or it is a thickening mass-like thickening involving the fundus and the adjoining bone?
Into the body and spreading across.
So there is a lesion in the fundus in the body, okay, which is thickened, which is a mass-like.
Yes,
Okay, I don't think there is an interluminal polypoidal mass as such,
yes, sir.
right? And what about the neck area?
So neck area appears to be free, sir.
Right. So neck area appears to be free. So there is a second lesion, which is causing obstruction of the common bile duct,
Yes, sir.
right?
Yes, sir.
Causing a stricture, and there are multiple lymph nodes. I think there are multiple lymph nodes in the hepatoduodenal ligament as well as in the intervertebral in the retroperitoneals. Okay.
Yes,
And aortocerebral, as well as total region. So I think there is a multiple hepatoduodenal ligament lymph nodes as well.
yes, sir.
But it is not the primary gallbladder region which is directly infiltrating into the hepatoduodenal ligament, which I feel so. What I could gather based on your CT scan videos. Is it right, Dr. Nagar?
No, sir. Actually,
Okay. So what is and the important thing is that anything else? You had a suspicion of gallstones, CBD stone.
yes, sir. I had a suspicion, but now as they were not able to appreciate any. There are no stones as such, no, sir.
So what is the cause of CBD stricture? If it is not a direct infiltration into the hepatoduodenal ligament.
Yes. There may be a lymph nodal spread, sir, huge lymph node which may be compressing the common bile duct.
So what next?
Sir, as it is a locally advanced disease, I would like
The
to
locally advanced disease or it is
and
a apparently metastatic disease?
query metastasis, sir. I would like to do a PET scan and know whether it is metastatic or not.
PET scan for confirmation.
I took a lymph node, sir.
Intervertebral lymph nodes and carotid.
Yes, sir.
Right.
Ideally, it should have been done, sir, but because of financial issues, we couldn't do it in our patient.
So what do we do now?
We also got one MRCP done, sir, to see clearly about the extrahepatic biliary duct invasion, which showed obstruction to 1 centimeter below the hilum, sir.
So do you have films?
Yes, sir. I have presented them. Yes, sir. Yeah, this picture, it is only a photo, sir, showing just below the hilum there was a cutoff, sir. And also below the insertion of cystic duct also there was some cutoff, sir, which can be appreciated in the video. Next slide, sir.
Gallbladder is distended, right? Cystic duct appears tortuous, dilated.
Yes,
Conference appears patent. There is a block below the conference, right?
yes,
It is a long segment block, and then you can see some portion of the CBD, maybe in the intrapancreatic portion. Right.
yes, sir.
So, what is the advantage of this MRCP? Does it make wiser now?
Yes, sir. We thought of seeing the extrahepatic biliary radical involvement clearly, so that we can plan accordingly, sir. and we proceeded with staging laparoscopy. And I
What
have
is your
to.
overall plan? What is your overall plan? So given this, you have CT scan, you have MRCP.
Yes, sir.
Right. So what is now overall plan?
Yes, sir. It is a stage T3 disease with extrahepatic bile duct invasion, sir. One with N nodes are present, but I would metastasis. I was doubtful, sir. M1 according to the CT, sir.
So what is your plan? Given this patient is locally advanced disease, right? It is not the direct infiltration of the peritoneal environment. Right? You have peritoneal environment.
Yes,
That area, the peritoneal area, and large lymph node. It is also jaundice, right?
yes.
It's a structure of the CBD, and we don't know about the vessel involvement status, right?
Most probably it is metastatic gallbladder disease, sir.
Most likely it is a metastatic gallbladder disease.
Yes, sir.
So what is your overall plan now?
Yes, sir. Firstly,
Just 5 minutes more, huh? It's already 10:04, so 5 minutes more. What is
Yes.
your plan?
I have to prove the metastasis, sir. One, and if it is metastatic, then I would like to do palliation as such. So, firstly, we got staging laparoscopy done, sir. Peritoneal metastasis were there, so we took
Just
intra.
hold it. Why not preoperative or image-guided FNC or biopsy from these lymph nodes?
Yes, sir, that can also be done. But initially, we thought that it was not neoplastic, sir, which iotocaval lymph nodes. The first reporting which was done, they told that iotocaval lymph nodes were 0.8 into 0.8 centimeters. And so
we are discussing about what we have in hand, right? So whatever you have discussed till now, as per those reports, those lymph nodes appear metastatic because those are large lymph nodes.
That would be a better option, sir. Getting a CT guided FNA.
Why to subject patient to a GA in surgical procedure?
Yes, sir. That would be a better option, sir. A CT guided FNA, prove it metastatic, then do palliation for the jaundice.
Yes, will go ahead with the palliative. Either you are simply standing or PTPT for
Yes, sir.
and then
Stenting.
So it is a different thing that you perform staging laparoscopy and you got to know that there are multiple peritoneal metastases.
Yes, yes.
Had it been peritoneal, we totally clean. Then what was the intent of your staging laparoscopy? It is only the staging laparoscopy or anything else besides staging laparoscopy?
Actually, we did staging, sir, and we thought of sampling the iotocaval lymph node, and if it was negative, we thought of proceeding it with radical chole, sir, with hepaticojejunostomy. But staging lab was done. Peritoneal mets were present, so we have.
What is the extent of CBD involvement in this patient?
1 centimeter, sir. 1 centimeter below the hilum, 1 centimeter length. So we thought we would resect the thing and do palliative HJ.
I really doubt that you could have done the RGU section if
Yes,
there was no peritoneal metastasis.
Hmm.
See, there were extensive lymph nodes.
Yes, sir. Then also we would have done iotocaval lymphadenectomy, sir, and we would have sampled it if it was
positive. I think my approach would have been different. Okay, with so much of lymph nodes.
Yes, sir.
If staging laparoscopy had been negative, right? I would just get the FNC from the mass, confirm the diagnosis,
yes, sir.
Do the biliary decompression, plan for the neoadjuvant therapy,
yes, sir.
assess the natural history and biology of the tumor, right? And then we go ahead with the definitive testing.
Yes, sir.
Rather than going for the definitive treatment at this stage, when patient is already having a jaundice,
yes,
right? There is an extensive lymph nodes which suggest that biology is not good because patient is having very short history of just 10 days.
Yes, sir.
So it is very unlikely that your even